Hello and welcome. I am Dr. Anil Joshi. Welcome you to my series that is ebook of radiography. Radiography book essentially deals with a technique of radiography, how to take a radiograph, what are the angles required to get a proper projection, what are the clinical indication, and what are the anatomical structure that are seen in this. The reason for all this thing is, unless we know what we want to see in a radiograph before, we cannot modify our technique, angulations accordingly and get that structure properly. Sometimes also the patients are in agony, that is a painful. Sometimes they are traumatic patients. Sometimes because of arthritis or otherwise their movements are restricted, or maybe because of their pain, irrespective of the cause. Then we have to modify different techniques. The ebook of radiography is a part of our website and is a part of the lecture series we are conducting, that is Learn Radiology Basics with Dr. Anil Joshi. So all these things are extensively put up and indexed on my website. Do visit to it for details of this topic as well as any additional topics of radiology, radiography, or of the different techniques. If you are looking for a procedure, if you are looking for the CT/MR cases, there is abundant such cases on the website. So also there are different lectures on YouTube covering all these things. At the onset itself, we want to disclaim about certain things. One thing is, this is a educational series. No matter of this series should be put up for a medical legal purpose or as a reference guideline. The aim of this is to teach our radiology students, radiography technology courses boys as well as the technicians, a correct art of taking x-rays. With this brief introduction, let's start the topic. Mind well, it's a radiation modality, and radiation has got effect as well as side effects. A care will be taken to minimize side effect of radiation by technologists, to protect patient, staff in the radiography room, to achieve maximum benefits with minimal side effects. A strict discipline and precaution is must. Everybody should follow a discipline, and whatever technologist is telling has to be followed properly. Now, how a radiation protection achieved? There is a different video made extensively on this topic, where we are not only given the radiation hazards but also how to protect. To just briefly tell here in radiography session, it's a distance because radiation follows inverse square law. Then second is the speed of exposure. The technologists adjust the speed of exposure in such a way that minimum exposure timing, the exposure will be on. So also barrier, shielding and personal protections. These things has to be kept in mind before entering a radiography room, before learning radiography, or before attending a patient. Now let us go to the topic first. Lumbar spine. AP is the first basic projection. Lumbar spine are usually asked, or requisition is for the lumbar spine, AP and lateral. So out of that, first let us see what is the AP. Now the indication are pain, that is back pain, then post-operative confirmation of prosthesis or position or location of the external fixators, then suspected lower limb cord or root compression. That's a clinical topic, but a clinician must be aware how it presents. Then suspected vertebral body pathology, either infective, traumatic, neoplastic, congenital or otherwise. A technician should know this before, because he is going to give position, he is going to see that patient's comfort, and he is going to avoid unnecessary pain precipitating factors. For that reason, he should know it before taking patient in radiography room, all these things. Now, once it is decided he is going to take the patient on the table, then he can take the radiographs in either standing or in supine position, depending on the indications and depending on the details a clinician want. The angulation is 0 in either degrees, then the distance is 100 centimeter, film size is 14 by 17, that is the maximum size of film we are using, and Bucky is always required. Bucky is required if it is you are dealing with CR or a conventional, which is still at certain places practice. But if it's a DR, then there is no question of Bucky. It's a direct imaging plate you are using. Now, AP view of the lumbar spine. lumbar curvature will cause distortion and magnification of the lumbar vertebrae situated away from the cassette. So whichever vertebrae are away from the cassette, whichever has got angulation, they will cause a distortion. Now for that, how technician should modify it? The patient's knee should be flexed in to diminish the effect by straightening the lumbar spine. Now this is important because a radiologist has to see all the borders of all vertebral bodies that is to be asked. Otherwise a serious mistake can be made, and this can easily be eliminated by proper position of the patient. You flex the legs so that entire spine touches the table. Then the lamina, spinous process and articular process will be seen through the vertebral bodies. So this is important as far as exposure factor is concerned. A technologist must see on monitor whatever X-rays are taken, and he has to see that clearly laminae, spinous process and articular processes are seen, because they are seen through the vertebral bodies. Adequate penetration, that is adequate KVs are needed for this. Then transverse process could be irregular or asymmetrical. Don't get bothered of it. It is not a pathological always, so you should know certain physiological dimensions or physiological distortions also. Now this is line diagram. Now where you take the center at L1 to L5. Now here it is shown as T12, that is where vertebrae starts, indicating that a central ray can be from L1 to L5 S1 or beyond that if you are suspecting any sacral or sacrococcygeal information is concerned. So depending on patient's clinical indication, depending on the asked, you change your central point. Now let's see a video how the radiographs are obtained. Now here we are seeing how a standing radiography is done. Most of the lumbar patient will have a nerve root compression, so it may or may not be possible for him to stand straight. However, there are certain clinical indications where we have to take a standing projection. This is a demo purpose, so the patient is standing well. Now what you have to check is the patient is in correct AP position, number one. Second, to centering of the central ray. Central ray can be from L1 to L5 or below depending on the indication. Now as far as LS spine is concerned, lumbosacral spine is concerned, there is no angulation to the tube, it is straight. So that is the way we position the patient, that is the way central angle is checked. And most important thing is you have to collimate at the end and see that if there is any distortion can be at lumbar level, it can also be at the shoulder level. So both are checked. Third is to contact, that the contact to the cassette has to be proper, that is checked, and we go for the exposure proper. Now these are the two X-rays which I am showing you. First X-ray is with, you can see where the centering is, the centering is L2, L3, while in second X-ray it is at L1. So L1, L2, L3, L4, L5 centering depends on the clinical indication, but by and large there is no angulation given. If you give angulation, that will be known because of the pelvic inlet. These views are totally different when we take AP with angulation. They are not for the lumbar spine, but they are for the pelvic inlet and outlet radiographs, which are not covered in this. But as far as LS spine is concerned, there is no angle, number one. Number two, patient's back has to rest totally over the couch so that there will not be any distortion of the vertebral body. You are seeing all the vertebrae, they are well placed, well outlines are seen, and the radiologist has got no complaint whatsoever. He has got no problem because all the pedicle, spinal process, transverse process are well seen. That is the main aim of radiographer. He has to check it and then send it for the reporting. Now let's come to the oblique projection. Oblique is a specialized projection which is not routinely asked unless there is an indication. Now what are the indication? Indication as usual is a pain. In pain, what we look into are the intervertebral foramina. Then post-operative patient, of course, for confirmation. Then most important, assessment of intervertebral foramina. IVF, they are best seen. Any osteophyte encroaching, size of the intervertebral foramina, they are best comparable in these. So if there is any suspected pathology, involving distortion of the interarticular phenomena. These are the ideal radiographs. But again, here you will have to take both sides to know the symmetry. Then pars interarticularis, especially a patient where spondylolysis is concerned. There may be spondylolisthesis or not, but if spondylolysis is suspected, this investigation is of gold standard, and even in the era of MRI, it is well preferred. It is best seen in this, and it's very simple technique. So the best use can be made in the patients where the spondylolysis is expected. Now, suspected vertebral pathology, infective traumatic neoplasty, these are the same as that of the APN lateral projection. Now, SI joint is an added indication. Now, SI joint are best seen in oblique projection. The first basic projection is PA and not AP because of the angulation. You can see what is the angulation of SI joint, where is how the central ray comes to it. Then you will know why the prone is preferred to SI joint, that is PA. But here we are discussing oblique projection, and oblique projection gives the best articular surfaces of SI joint, and even in the era of the MRI, it is still preferred when you are suspecting something of the SI joints. It's very simple, is to take both obliques and see the articular surfaces of SI joint, and pars interarticularis, as I told you, is another definitively still even today indicated view. Now, patient either standing or decubitus on the table with angulation of 25 to 45 degrees as per clinical indication. This we have to adjust as per the clinical structure, as per the results of the first radiograph. In first radiograph, you are finding some problem, you want to know certain more ocular detail, then you can modify this angle. It's very easy technique and it can give you the best possible results. But if you are comparing symmetrical, please take care that both are with same angulation. Then there is no angulation as far as patient is concerned, but as far as tube is concerned, the angulation is 0. Then the distance is 100 centimeter, cassette usually 14 by 17, and Bucky is always used because we want to have a very clear picture. So Bucky is indicated. Now, what are the important point? Then patient is placed obliquely over the table at 25 to 45 degrees angulation. The coronal plane passing through the spinous process is centered to the midline of the table. Then the lower apophyseal joints are of the interest. The central ray should pass through the level of raised iliac crest. Iliac crest is L3. So L3 downward, 4, 5. Your central ray has to be below the iliac crest, number 1. And second thing, iliac crest is a barrier to block the X-rays, so you will have to give more exposures. The KV has to be more for L4, L5. They are not as much required for L1 to 3 because the ilium or iliac crest is not overlapping. So overlapping of iliac crest, a technologist should know so that the exposure is adjusted, or when you are seeing it on the console, you can get it properly. A view of upper lumbar epiphyseal joint is desired. The central ray should pass through a point 1 inch above the raised iliac crest. So iliac crest is a landmark as far as oblique is concerned, and as per the indication, you go above or below. These are the two important things. Now, the apophyseal joint, which is close to the film, when you make oblique, will be a properly projected iliac. It will be properly projected apophyseal joint. A different degree angulation may be needed to obtain a clear view of all apophyseal joints, since the plane of the joint varies. This is a personal variation, individual variation, and the technologist should be aware. He should change the angles and, if required, repeat the X-ray. The sacroiliac joint, which is further raised from the film, will be imaged properly. So when you are imaging right apophyseal joints, a right pars interarticularis, the SI joint you are seeing is left, that is the opposite side. That's how you have to manage it. Now these are the oblique projections you can see here. Center is at L3. But most common pathologies are L4, L5 as far as spondylolysis are concerned, and it's a very common cause as far as young patient coming with back pain are concerned. So a lot of time we have to take this when we do not find much pathologies in young patient for back pain. This projection gives a gold standard information, a valuable information. Now let's see how the X-rays are taken. instructions to the patient. Now patient is supine on the table. Here whichever pars interarticularis you want goes near to the table, and whichever SI joint you want goes far from the film or far from the cassette. Now see, patient is made central ray at iliac crest, that is L3, L4, and we are trying to give the position to the patient. Now this is left side, we are turning patient. So this is a left-sided pars interarticularis, left-sided intervertebral foramina, and right-sided SI joint will be projected in it. The angle should be between 15 to 45 depending on clinical indication, and often you have to correct it and take it again. So once you go to one side, you go to opposite side also, because a comparative for intervertebral foramina are always preferred. So we always prefer in that way that both side intervertebral foramina are available and they can be compared. 100 cm distance, then central ray around iliac crest, and that's how you see that everything is okay. A radiograph is shot, and then you put it for the processing. Now these two oblique views we are seeing. Here the most important thing, these are taken for the spondylolysis. Now this picture shows you a Scotty dog appearance. Now this is the mouth of a dog, this is the ears, this is a belt. The belt indicates a breach or defect in the pars interarticularis which correspond to spondylolysis. These are the front legs of a dog. So that's how it is described as a Scotty dog appearance. Here you are seeing lot of such Scotty dog appearances. This is the best in here. This is the eye, this is the mouth, these are the ears, then this is the neck. If at all there will be spondylolysis, it will be seen here. Now there is no spondylolysis here, and if at all you want to have a better idea about intervertebral foramina, the angulation you give is a less. If you want SI joint, your angulation are slightly more. But of course, these all depend on the clinical indications. And after one X-ray, if you find that there is something more is needed, then you go for it again. You change the angle and you get the best possible result, so that interpretation can be made by a radiologist according to the wish of a clinician, and patient is benefited. Now, what are the indications? Indications are again that of the vertebral pathologies, that is the pain, post-operative confirmation of the prosthesis, suspected root compression. Here the added advantage are the disc spaces visualization. Like in oblique, it is intervertebral foramina. In lateral, it is the disc spaces and the margins of the disc, that is the articular surfaces adjoining, are the best seen in the lateral projection. Now here patient either standing or decubitus on table, then central ray is at L3, L4 as well routine is concerned, but with pathology suspected lower down. Often there are two different projections we take. First is from T11 to something like L3, L4, and which the anatomical structure which are below the iliac crest, that is L4, L5 vertebral body, L5 is vertebral body, we might have to take a different projection for the lateral, which is more penetrating. So by and large in one film, DL junction and L5S1 along with the mid-vertebral bodies are not properly seen. You will have to adjust the technique, as well as sometimes you will have to repeat the X-ray with a proper penetration. Now the distance is 100 cm, film size is 14 by 17, and Bucky is required to get a clear picture. Now let's see. The point of interest is patient is immobilized by flexing hips and knee. If patient is a straight hip and knee, he will either bend forward or backward. He will not be stable. One. Second thing, the exposures of lumbar spine are long exposures. So you need a stable patient. To stabilize the patient, we do two things. One thing is you flex the hips and knees so that his pelvic girdle will be fixed and shoulder girdle will be fixed by holding edge of the table by the hands of the patient, and one hand patient should keep below the head. So that is a perfectly positioned patient from where you can take good X-rays. The coronal plane passing 3 inches posterior to the mid-axillary line is adjusted to the longitudinal plane of the table. Then a folded sheet bolster is placed in the depression above the iliac crest, that is to prevent a distortion. Now, how you see that they are correct? You palpate the vertebral bodies and see that the all vertebral body will be parallel to the table. So they have to be parallel, otherwise they will get distorted. You will not get good intervertebral space. Although the film here is demonstrated immediately beneath the patient, a Potter-Becky diaphragm is always employed. The reason is here what we used are the DR cassettes. Now Potter-Becky are used for the CR cassettes, and if you are asking for a lower sacral or coccygeal, then the technique employed is different. You have to get a softer exposure. They need less exposure because there is no iliac crest overlapping then. Now here you are seeing how a lateral projection looks like and where they are centered. Now let's go to the video. Perfectly lateral position patient. Now position of a cassette depends on what is the indication. You palpate iliac crest, that corresponds to L3 level. Now your centering is either L3 or slightly below it as per clinical indications. Now here it is easy to make patient straight because patient is stable. If it is on table, you have to see by palpating spinous process that the spine is horizontal to the X-ray table. So that's how the X-rays are taken for the lateral. Routinely, lumbar epilateral are enough. The additional X-rays like flexion, extension are taken only when instability is suspected. Now, dynamism is an advantage of X-rays over MR. Dynamism is you can take the flexion and extension to know whether there is any movement. Now see, this is how the flexion is done. That is to see the movement. This is extension now. So we have to go for a neutral, flexion and extension. Here sometime you will have to use a horizontal cassette if the patient is not fitting in a single cassette, number one. Number two, if the area of interest are larger. Now here cassette is adjusted, again L4, L3 is the center. A perfect true lateral is essential. So also a centering at L3 level is mandatory when you are taking these X-rays. So that is a technique of flexion. Extension will be similar. Now let us see a video demonstrating how a extension radiograph is taken. Here you have to take care that the patient will not fall down. For flexion it is easy, but for extension a slightly, because this patient has got pain, they have got a neuronal deficit, so may not be, it is easy to show how it is to be done, but sometimes it is difficult for a patient. He has to keep the plane same. Now see, the hand is coming in the way. It is adjusted so that the true lateral comes. A technologist has to see all these things, and once the patient is placed properly, you can go for exposures. Now centering will depend on the area of interest, whether you are not L1, L2 or L3. Another thing which is important here are the scoliosis workup. In scoliosis you have to have a lateral bending, that is right lateral bending and left lateral bending. Now as far as scoliosis workup is concerned, it is not covered in this lecture. This is one side bending, then this is the second side bending. Side to side bending is extremely essential. Again, I want to tell here one thing. Sometimes it is not possible for a patient and we have to take care that patient will not fall down. But this scoliosis workup is taken when patient is standing. No point in taking when they are on the table. So we take it in standing. Unless it is clinically indicated that patient cannot stand, then only you will have to go for a supine lateral bending, forward bending. But forward bending is not possible in supine. It has to be patients standing, and it is all described in a standing patients. So either we go for a standing or we abandon the procedure if it is not possible for a patient. All the angles, all the scoliosis workup is over the standing patient and taken with these three radiographs of straight, lateral bending right side and left side. Now let us come to the lateral projections. Now we are showing you two. Now first you will see is practically 5, 4, 3, 2, 1, 12, 11, 10. So big vertebral span is covered in this. And if you see the centering, it is at L2, L3. So this is centered at L2, L3. And this X-ray, the centering is at L5, S1. Now you can see the shadows of iliac crest. Iliac crest requires more exposure. So if you want to see this vertebral body, this intervertebral disc spaces, your exposure has to be higher. And if you want to get X-rays like this, your spinous process has to be parallel to the film, otherwise you will get distortion of the vertebral bodies. So that is the skill of a technician. Now these are the flexion and extension. Now what they are showing is, if you see here, this is 4-5 disc. Observe here this 4-5 disc, 5-4. Observe here the disc space, number 1. Number 2, see the position of the L4 and L5. Whether there is instability, they are moving. See the posterior position. Here also you see the posterior position. So these three things you will have to see. One thing is the vertebral body position, whether they are moving or not. Number 2, intervertebral discus spaces. You can easily observe that L4-5 vertebral disc as well as other vertebral disc spaces, and you can clearly get what is the advantage of flexion and extension X-rays, and that will give you a perfect diagnosis of the affected disc as well as instability which surgeons need for the operative workup for fixing and otherwise. This is the scoliosis workup. Now to how see detailed angles of the scoliosis is not a part of this lecture. They are covered in some other lecture and they are covered in some other video. Here the basic aim is as far as radiographic projections are concerned. Now here we are seeing one, this is two different cases but different ways the thing are work up in lateral bending, AP and lateral bending. We have seen a major radiographic projection as far as lumbar spine, lumbosacral spine is concerned. We have seen in more detail which positions are required for pars interarticularis, intervertebral phenomena, discus spaces, assessment of vertebral bodies. We have seen projection which are required for scoliosis workup as well as instability workup. And with all these things, as far as lumbar spine is concerned, we are covering major projections. However, different diseases, there are different techniques involved, there are different views, there are different angles which are not all covered in this. These are the grossly what we need in our day-to-day routine. Special views are there and sometime in other videos they will be covered. I thank you for giving me your valuable time. Please note, radiology is not a race, it's a process. Be part of it and enjoy the feast of knowledge. I am Dr. Anil Joshi logging off till we meet again. The basic aim to produce this series is to give you idea about what are the types of projections and what are the precautions to be taken. They are important because a patient comes with a referral letter stating that which X-rays are to be taken. Now when X-rays goes to the radiologist, he is looking as per the clinical indications. Now after seeing that referral letter, a clinician has to analyze which is the anatomical structure he is looking for. He has to adjust with the patient's clinical condition. Patient may be in agony, patient may not be cooperative, patient may be irritable. With all these things, he will have to find out what exactly is required from that patient so that a good diagnosis will give him a speedy recovery. I acknowledge with thanks, with and gratitude, my mentors, that is the management of BLDE deemed university. I am working and the videos are prepared in Sri B.M. Patil Medical College Research Center at Vijayapur. I also acknowledge with thanks the staff of Radiology Diagnosis Department for the active participation, and IT and Photography Department, without whom it would not have been possible for me to complete this video. Thank you, take care, and give your best to the patient.